Greetings to all the delegates from Department of Nuclear Medicine, Amrita Institute of Medical Sciences. I am Dr. Shanmuga Sundaram. I am the clinical professor and head of the Department of Nuclear Medicine. And on behalf of my team members and also my institute, I have the great privilege of inviting all of you and a warm welcome to all the delegates. This is the Amrita Online International Lecture Series as part of our department's Silver Jubilee celebrations, where we wanted to have the lectures by luminaries in the respective fields. And as part of this series, today is the third lecture on thyroid, and today's luminary Dr. Marcus Luster. I have great pleasure and privilege to introduce Dr. Marcus Luster. He is the professor and head of the Department of Nuclear Medicine, University of Marburg, Germany. He is the present president of German Nuclear Medicine Association. He has also been a member of EORTC Endocrine Tumor Task Force since 2010, apart from being a member of the Pediatric Thyroid Cancer Guidelines Task Force, American Thyroid Association since 2010. He was also the chairman of Thyroid Committee of EANM during 2014 to 2020. Apart from being a luminary in thyroid cancer management, Dr. Luster is an expert in pediatric oncology and also nuclear endocrinology. He has more than 335 research publications with more than 14,000 citations. That clearly shows how big he is an expert in both in thyroid cancer management and also as a general nuclear medicine physician. Today's lecture, he is going to talk on changing pattern of thyroid cancer management and the evolving role of nuclear medicine. Before handing over this virtual platform to Dr. Marcus Luster, I like to make two announcements. One is we will, even if this Zoom link is getting filled with 100 participants, there is a YouTube link also, so you can very well join in this live YouTube channel. And the next one is, please feel free to put your comments and also your queries to the chat box. Thereby, I can collate and I can put it up to Dr. Marcus Luster at the end of his talk. Thank you very much for everyone for joining in this virtual lecture on thyroid cancer. And at this point, I like to invite once more Dr. Marcus Luster for this lecture series. And I'm handing over the virtual platform Zoom to Dr. Luster. I request my technical team to allow him to share his screen.
Good evening, good afternoon from Germany, and thank you very much, Dr. Sundaram, for the kind invitation. It's a great pleasure and certainly an honor to be part of this prestigious series, and congratulations to your Silver Jubilee, of course. As you know, I've been around several times in India and also had a chance to see your institution, and I'm always impressed by the high standards. So I like to contribute to this series and like to talk about thyroid cancer. And just by looking at the title, I think we may discuss some eminent changes in the treatment of thyroid cancer. I'm going to share my screen now. I hope you can see my screen. Just a small okay would be great.
Yes, Dr. Luster, we are able to see your screen and we are able to hear you very well. Thank you.
Thank you very much. And I also like to thank the colleagues joining us this evening on a Saturday evening. I really appreciate your presence, and I hope you will also find some time for discussing your cases or whatever comes up during my presentation.
Dr. Luster, we have more than 100 participants already. Thank you.
That sounds great. So that sounds stimulating and motivating for me. So I do my best.
Thank you very much, Luster.
Thank you. I wanted to just show you my disclosures. How does this? Let me check. Does not. Oh, here you go. Okay. So these are my disclosures, and I'm always proud to show those because it's not only that I'm cooperating with several pharmaceutical companies, as you can see on the left-hand side, and I think that's necessary to work and cooperate with industry. There is no progress just academically driven. It needs to be a balance, but I think it's important. But even more proud to be part of several patient support groups. So basically, I'm a member of the German patient support group, the Thyroid Cancer Alliance, an international group, and the Butterfly Cancer Trust, which is based in the UK. And I'm serving on their advisory board, which makes me really proud. Thyroid cancer is rather not one disease, but a bouquet of different diseases. So there's a whole spectrum, and they all need to be treated differently, of course. If you look at an ATC or, let's say, pituitary thyroid cancer, these are two different animals. Over the last few years, I had a chance to cooperate with various colleagues from international institutions, societies, associations on the guideline formulation. And recently, the ongoing project is the ESMO, the European Society of Medical Oncology, which will be out soon. But if you have, and this is not a complete list of guidelines, you can see that there are multiple and, of course, several national guidelines as well. And I'm always asking myself if we need like tons of guidelines, all based on the same level of evidence. And you are well aware that evidence levels, especially when it comes to differentiated thyroid cancers, is pretty low as compared to, let's say, if you look at the prostate cancer guidelines or neuroendocrines, there are many more prospective randomized studies in well-differentiated thyroid cancer. These studies are sparse for various reasons. One of the reasons, of course, being the excellent prognosis of the disease, and I'm coming back to that in a minute. Just recently, we had an effort to at least combine the two guidelines across the Atlantic. So we had a joint publication shared between the ENM, the European Association, and the Society of Nuclear Medicine in the States. And I think that was a great achievement. And we also tried to get some other associations on board, but we were not successful this time. But at least now we have a joint guideline from the two sort of leading nuclear medicine societies. As I already pointed out, the thyroid cancer spectrum is large. It reaches from well-differentiated and less well-differentiated tumors to really anaplastic and undifferentiated tumors with the worst prognosis. And recently, there was a change in the WHO classification system, which is good in a way. On the other hand, it sometimes also irritates a little because now you have to transfer prior findings, prior classifications to a new system. And that causes, at least to my understanding, some problems from time to time. And also, there have been new kind of thyroid carcinoma introduced, like the differentiated high-grade thyroid carcinoma, which was not the case in the last WHO classification. But I will try my best to put you through this new classification. As you might know, I had a chance and the privilege to be part of this initiative a few years ago. We were invited by the US and European groups from nuclear medicine and endocrinology to the island of Martinique, and we had a very fruitful and very intense meeting there with several colleagues from both sides of the Atlantic. And finally, we decided to have some statements. We did dare to call them principles. And I might refer you to this publication, because at least my impression, my personal impression was that once you sit together for a few days, almost for a week, and discuss all these different aspects, how patients would be treated in the US versus Europe, and by nuclear medicine physicians versus endocrinologists or endocrine surgeons, the level of understanding, of course, rises, and you tend to better appreciate what colleagues would be doing and what would be their reasons in a given setting. So for me, this was a great initiative, and I'm still benefiting from these experiences. Recently, I've been invited by the International Atomic Agency based in Vienna, and they were smart enough to ask the question, the use of radioiodine in DTC, is there a right answer? And I believe there's not. So there are multiple aspects, multiple features one could consider if a treatment is right or wrong, about activity and all that stuff. And about 2 weeks from now, there will be another initiative chaired by people from the IAEA. So they came up with the idea that although there are several guidelines, most of them would be linked to, let's say, highly developed countries with specialists and expert centers, access to all kinds of treatments and medications. So they have the goal, and I'm happy to be part of that, although it sounds challenging, to have a set of guidelines for less developed countries with less access to modern medication, even recombinant TSH or all the new tyrosine kinase, multikinase inhibitors. So we will work on that, and there will be colleagues from almost across the world, and we try to address the questions that might be different in different settings. I'm looking forward to that. This will be end of the month in Vienna. And finally, I believe that politics, as always, play a role in the management when there is a pretty low evidence and not enough experience to really base firm decisions on. One may be prone to too much expert opinion and too much discussion that is ego-centered. So ideological differences may play a role, and this is also reflected by guidelines that look, as I said, different, although the evidence is the same. So what we really would need is more controlled randomized trials, of course. So we are actually in a process to set up one more study, prospective study in our framework, like Germany as being a borderline iodine deficient country with a lot of goiters present, a lot of surgery for benign conditions, or what is supposed to be benign conditions. So we might have a little bit of a different patient sample in Germany. But overall, it would be great to have more prospective trials. But I understand that prostate cancer, PSMA, and alpha therapy is probably more sexy these days than good old radioiodine. But I'm still a fan, as you can see by my presentation. So we still have no clear-cut evidence when to stop treatment, how to assess treatment, and we need to sometimes base our discussions just on decisions just on personal experience and gut feeling. And there are, of course, several factors you will never find listed in the guidelines, but they may well influence your decision making. And frankly, this is also linked to reimbursement policies. So what's the duration of a procedure? Do you have to hospitalize a patient for various treatments or even diagnostic scanning, which is the case in Germany? And of course, this is heavily influencing the reimbursement as a whole. And we have different insurance status, like private, public, in some countries even no insurance. You're standing within a medical faculty. If you're part of an academic institution, if you have a lot of patients and a lot of procedures, they may love it. I don't know what's the influence in India, but I would guess there's also some economic implication at least. And finally, and I'll come back to that in a minute, patient participation plays a more important role these days, and shared decision making is becoming bigger and bigger, at least in Europe, because putting yourself in the patient's shoes, because if there is not so much evidence, I think you want to be presented the accessible information in an understandable fashion, and that's what we try to do and what we try to standardize these days. But anyway, we have a very successful treatment with radioiodine, even without any kind of personalization, and there's a strong potential to even improve the outcome. So shared decision-making, if you want to read that up with my colleague, Dr. Alsberger, and Dr. Reiners, my former mentor and boss, we put some ideas together in this paper. And here is a photo I like very much about shared decision-making, because it always takes two. It needs an open-minded patient, and of course, it also needs an open-minded doctor willing to share his or her experience and ideas with a given patient. And there are different animals out there. There are so-called minimalists and there are so-called maximalists, somebody who's willing to take some risks, of course, not only when it comes to health issues, but in general. Others would stay away from the kitchen anyway. And on the other hand, some people would be more enthusiastic about modern approaches and technology, medicine included. Others would believe in natural approaches, and the body should help itself. But there's a huge gray zone, and this is why I believe you need to talk to the patient to come to joint decision-making. Coming back to the guidelines, this is the SNMI E&M practice guideline. And on the other hand, and probably also a little bit on the other end of the spectrum, there was the ETA consensus statement. We didn't dare to call that a guideline because it does not fulfill, when it comes to evidence classification and recommendation grading, it does not really fulfill the standards of a guideline. But anyway, I was part of both initiatives, and that was a tough one for me because sometimes these guidelines at least seem to contradict each other, and people would ask if I'm schizophrenic being part of both. But then in the end, there were several statements regarding this presentation, like even from my home country, there were some colleagues asking for an individualized treatment, which would still be based on endocrine surgery and radioiodine therapy. The ENM thyroid task group committee was smart enough to really compare these two guidelines, and they finally, which is, you don't have to go through this busy slide, but if you have a quick look, you can tell probably that it's all about wording, and boiling it down, there is not too much of a difference. So if we call it selective use for the ETA and in general for the ENM, so what's the difference? You have to decide on a patient individual basis. If you go for recombinant TSH preferred or both modalities, and even for the activities used for the various procedures, there's enough overlap to still live with both guidelines. That's at least my take. So as I said, a lot of ideological differences, not too much controversy. Coming back to the level of evidence, and again, this is too busy to really take you through the whole slide. But a few years ago, we sat together in a very nice group and assessed the evidence for the treatment of children suffering from differentiated thyroid cancer. And all the questions, we started putting questions to ourselves, summarizing the questions, and then looking for evidence by a structured literature search using different databases. And you can see for all these really important and essential questions, like what's the best tool for preoperative staging? What about postoperative staging? What about genetic testing? Should we do genetic testing in the child? And we always came to the conclusion there is no evidence and all would be based on expert opinion. And it's not that different when it comes to adult thyroid cancer. There is not enough evidence to really have a firm recommendation. Still, the overall prognosis of differentiated thyroid cancer is very good. This is a little older data, but it didn't change over the last decade or so. This is from my former institution when I was based in Würzburg, and you can see that stages 1, 2, and 3, the life expectancy does not differ between patients affected by thyroid cancer and the normal population, the general population. Only in stage 4, when we're talking about high risk metastasized thyroid cancer, this is when the disease is really impacting on the overall survival. You see the dotted lines would be expected, and this is thyroid cancer straight lines. So we have to always ask ourselves, and that's what we do on a regular basis, we should not overtreat a patient, and we certainly should not undertreat. So the key and the clue to optimal treatment should be a risk assessment, initial, and it should also be an ongoing procedure. So after every intervention and after time has passed, you should always reevaluate and probably ask yourself, am I still on the right way? And one tool to help steering patient career is, of course, the recent, not so recent, the ATA guidelines, which will be updated soon, as far as I know. So besides all these very objective features, of course, you have to look at local factors, like what's the quality of the pre and post-operative ultrasound, what is the experience of the surgical team, and what's the quality and reliability of all your lab values. On top of that, what's the quality of the information in the pathological report? Is there a minimum number of lymph nodes being resected? So you could call a patient N0 or N1 or whatever. And to really come to a conclusive idea, you need a certain number of lymph nodes being resected to have a 90% certainty that the patient would be free of lymph node involvement. You can see the numbers here increasing with tumor stage. And we all know that especially in papillary thyroid cancer, the number of lymph nodes is quite high as compared to other diseases, and it's especially high in young patients. But when it comes to nuclear medicine, when it comes to our specialty, there's room for improvement. And Flavio Foa from Switzerland took a very smart approach, and he actually sent like an index patient to the former thyroid committee of the ENM when I was chairing it, asking each individual in the group what he or she would be administering or advocating for a given tumor stage. So you can see for low risk tumors on the left-hand side and for higher risk tumors on the right-hand side. And one would hope, one would guess that there would be much overlap in all these. This is always a single doctor here. Every dot is a single doctor. And you can see the whole spectrum of recommendations also in the high-risk group and in the low-risk group. From 0 to 4,000 megabecs, everything's possible. Anything goes, so to speak. And I think this should not be the case. So some kind of standardization, and this was an index patient, this was not real life, we should be aiming for. In Germany, in my home country, the number of procedures, radioiodine therapies, goes down continuously. So we're following the international advice to a certain extent. It's still relatively high compared to other countries. And the number of new treatments like PSMA and dotatate, does not completely compensate for that, but this is data only in 2020. So now, at least in our hands, PSMA really catches up. And I also listened to Michael Hoffman's presentation. There's so many studies ongoing. So I think in the future, we will have a lot of work with all prostate cancer patients. Again, from the Martinique principles, I think we have to define our goals, what we really want to achieve with our therapy. Is it just remnant ablation, which is probably not necessary in every patient? Are we aiming for adjuvant treatment, or is it treatment of known metastasis or remnants or tumor? And then the next step would be to have a structured report to really assess response to treatment. And you all know the criteria. Again, I'm always trying to rely on the standard that was defined by our friends from the US. And I think this is very helpful to have all these tools like excellent response and biochemical incomplete, indeterminate, and structural incomplete. I think if we all stick to the same terminology, that makes it much easier not only to follow our patients, but also to compare results from various institutions. So there was, of course, several rating schemes applied and invented for high-risk tumors. Like if you want to register a tyrosine kinase inhibitor, of course, you need RECIST criteria. But this is not so much the case when it comes to radioactive iodine. So all these criteria seem to be more subjective and hardly comparable. So what would we call radioiodine resistance, and how do we interpret results from various institutions? So even if you want to skip radioactive iodine, most of the studies are based on this approach. So there is not too much data out there showing you what happens if you skip several procedures, less than total thyroidectomy or radioactive iodine. So we need to really assess this in the future and to see if we can really skip some of the more aggressive approaches in low-risk patients. And most of the rating schemes are, of course, not designed or even tested to guide your decision. They're more prognostic tools. The French published a very nice study a few years ago, enrollment of about 750 patients. They compared pretty low activity of radioiodine in low-risk patients versus watch and wait after thyroidectomy. And they had basically PT1A to PT2B and 0 or NX, and used radioiodine versus no radioiodine, and had two assessments after 3 and 5 years. And the outcome was that the no radioactive iodine was as good as the outcome was about the same after 3 years. So the number of events was the same for both arms. There was some criticism, of course. One is that the amount of radioactive iodine was pretty low as compared to other centers. The definition of low-risk patients was not so clear. In our hands, this would even be very low-risk patients. And in low-risk patients, you need a longer follow-up. So now it's 5 years. Probably one should extend to 10 or even 20 years. Just a few words about dosimetry. Some of you might know that I'm a great fan of dosimetry because it doesn't make sense to treat every patient with the same amount of radioactive iodine. Like at least in our hands or in many institutions, a young man, 200 kilogram, would be treated like an elderly lady. The blood volume is completely different, and Glenn Flux said but nowadays, the administrations are based on nationality rather than radioiodine kinetics, and I think he's right. So there's an ongoing battle about the usefulness of dosimetry. This also may play a role for risk assessment. There has been a study out there. I'm not in a total agreement, but at least we have to be aware that the potential risks to different organs when it comes to radioactive iodine treatment. But even these colleagues concluded that we need a multidisciplinary team and a shared decision-making. So it's a surprise that we don't know enough, but don't know so much about the impact of radioactive iodine, even after we've been using it for 80 years or more. So risk stratification, as I told you, is important. We need a uniform system, and we need functional imaging, not only radioiodine, but also glucose and some other markers. And I'm going to present you a little more on the more aggressive tumors in the second part. So let me start my second part with the up-to-date WHO classification. And there are basically 3 aspects. One is the origin and the differentiation, more important and growing importance of the gene mutations, and also the histopharmacological features, of course. This is quite complex, but basically there are various tumors, the RAS-like tumors, the RAF-like tumors, and the high-grade carcinoma. This is part of the new WHO classification, of course, the anaplastics. On the left-hand side, there would be oncocytic tumors and the well-differentiated tumors. And these are the changes. Again, I would like to refer you to the original publications. This is too much to go over it in detail. But once you have a pathology report, you should be clear if it's the new WHO classification or the old one. And if you look at the patient history, there are certain changes. And we learn a lot, and we learned a lot over the last few years about the evolving role of a nodule in a thyroid and all the different markers and of course, the signaling pathways. And some of those findings also led to targeted therapies I don't know what the situation in India would be, even in Europe. Not everybody has access to every drug. And even for us, it's sometimes hard. We need approval by the insurances to use some of the new drugs. But it is a changing pattern here, that's for sure. The high-grade tumors have several features. It is certainly the growth pattern, it is nuclear findings, it's other conditions like mitosis and tumor necrosis being present. And all these features, or some of the features, are listed here. You see the histological subtypes, and you see the markers. And this is not only academic, this also leads to certain manifestations, so you can tell what the risk of having lung or bone metastasis would be by just looking at the molecular markers. Of course, the linkage is not 100%, but the risk could be estimated, and radii-iodine avidity could also be estimated. So you probably should look for a different strategy, more close monitoring, probably even more aggressive treatment in some patients. So here you see some of the molecular features like BRAF, TERT, and TP53, which also impacts on the time to a patient becoming radioiodine refractory. And you can see that, look at the TERT promoter, if this is positive, the risk of becoming radioiodine resistant is much higher. So this is a patient, again, showing some uptake here on the iodine scan, but heavily involved mediastinal lymph nodes and lung in the glucose scan. So we would also do an FDG PET-CT in every high-risk patient. And the frequency of TERT mutations goes up with age, and it also impacts on the overall survival, no matter what the treatment would be. So TERT positive patients have lower life expectancy. And the good old days, we were believing that we could call the type of imaging result a flip-flop phenomenon. So make our lives easy, less aggressive, well-differentiated would be iodine positive, even the lung metastasis, and vice versa. And a poorly differentiated cancer, you have a higher glucose uptake. But of course, this is again a spectrum of diseases, and there is no clear-cut difference here. But still, it holds true that if the FDG uptake is high, you're dealing with a more aggressive tumor, of course. And you also have to consider additional factors like the increase of the thyroglobulin and, of course, the absolute value. And imaging may also play a role, and a growing role, in response evaluation and prognosis. This is one patient, more serious. You see a glucose uptake in the lung here, and nothing in the neck. Same patient, and you see this is probably benign thyroid remnant. So even in the same patient, you can find different patterns. Another patient from our series just recently, just the opposite thing. You can see that in radioiodine, there is uptake in the metastasis, and the same holds true for glucose. So it's positive in both imaging modalities, whatever that, even in the local tumor remnant here, positive in both imaging modalities, whatever that may lead us to. Another example here, this is the first imaging. This was I also put the thyroglobulin values on the slide because I didn't come across a high-dose hook effect. Some of the young ones probably don't even know high-dose hook effect. It's false negative TG values. So in the initial assessment, there was a pretty low TG and was retested because of the so-called high-dose hook effect. It was higher than 200,000. This was caused by this huge liver metastasis. You could see this is the FDG PET, but there was also radioiodine positive. In this special case, we still decided, because it was also causing some problems, some abdominal pain to the patient, to go for a resection. And this is the post-operative radiiodine scan. You can see the liver metastasis was resected, and now we can concentrate on the other metastases. Once a patient loses radiiodine uptake or response, of course, the overall survival is drastically decreased, which was also shown several years ago and still holds true. If you lose radiiodine uptake and become radiiodine refractory, you're in trouble. But this is not a clear-cut decision, it's just degrees of likelihood, and that various criteria you should follow. So even if a patient has some uptake, does not necessarily mean he or she will respond to the treatment. And of course, all these criteria probably evolve over time, also taking into account technical issues, optimized imaging, and redifferentiation therapies becoming more important in our hands. So if you have a patient, you probably should refer to a more experienced center and really look at the scan quality, because not all scans are created equal. So as I said, even a negative diagnostic scan is not completely sacrosanct, and the presence of radiant uptake is not automatically leading to some response. Some authors would argue that there's a maximum radioactive activity that could be applied. I'm not in agreement here. I sometimes treat patients with a lot more if there is still a response to the treatment. So where are we? Radiiodine refractory carcinoma. Some patients may even benefit from watchful waiting added by local therapies, systemic therapies, of course, TKIs, and sometimes redifferentiation. There are several treatment algorithms. And as I already told you, some of the new algorithms are linked to the molecular markers, and you can exactly address several aspects of this cascade. So this is the treatment algorithm from the ESMO guidelines. This will be refreshed soon, but I refer you to the Annals of Oncology, where probably there in a few months there will be a new set of guidelines by the ESMO. Again, a little bit complex here, but I just want to focus your attention on the right-hand side. You see systemic therapy. We have multiple options now. Just 10 years ago, we were lacking treatment options for patients affected by aggressive thyroid cancer. Now we have a whole arsenal to address these diseases. And even these authors, it's a Canadian consensus published in Frontiers in Oncology, they acknowledge that true radioactive iodine refractoriness is just convincingly shown by attempting radioiodine therapy. So you couldn't call a patient radioiodine refractory if you did not at least give it a try. And I mentioned the various drugs that are in use. In Germany, at least there is sorafenib and lenvatinib as first-line treatments, and cabozantinib as second-line treatments, and all the other drugs are on a patient use basis, but we try to use them once we run out of options here. You all know the pivotal trials. This is the one on sorafenib 10 years ago by Marsha Bros. And you can see the superiority of sorafenib treatment as compared to the placebo arm. These days, the number of treatments with sorafenib is really going down because of the spectrum of side effects. We tend to prefer lenvatinib these days. It's better tolerated. It also has side effects, but the tolerances and the spectrum of side effects is probably preferable for lenvatinib. Nice example here of the response to lenvatinib in a patient suffering again from widespread disease. And you can see after 3 months of lenvatinib, most of the disease would be gone, and you can assess that nicely by the FDG scan. This is just a brief overview of the side effects. You can see what really impacts on the quality of life in sorafenib was the hand-foot syndrome. On the other hand, you always have to have a look on the heart action, and most of the patients would also be complaining of fatigue, in many cases also leading to dose modifications, including drug holidays. Recently, there was a third drug approved, a second-line treatment. It's cabozantinib, also showing a superior PFS and a sort of superior overall survival, although there was a crossover like in the other studies as well. So if you have this crossover effect, you can really assess the overall survival. Just a few words on, let's say, very modern and at least in part experimental drugs. NTRK fusion is an option, and the drug would be called larotrectinib. It's very well tolerated. Even in our hands, patients don't suffer, but the number of patients in our hands is lower than what was postulated by the first publications and abstracts. Then we have the so-called selpercatinib, also used in medullary thyroid cancer. Again, excellent results if you have a look at the waterfall plot, but again, this is a niche indication, just a niche of patients. This is from our institution, and you can see the number of fusions and alterations, gene alterations, is pretty low. So we always do a testing, but only a minority of patients would qualify for the drug. Redifferentiation, very interesting, being nuclear medicine, fascinating. If you could reinduce the sodium iodine symporter, there have been several studies out there. This is the one from Essen, Germany. But it's a limited patient number so far. It was a prospective 2-arm phase 2 studies. Patients received trametinib or trametinib plus dabrafenib if they were mutated BRAF for 3 weeks or so. And then it was assessed by iodine 1 to 3 imaging and followed if the uptake would qualify, followed by therapy. And the results were okay, so to speak, redifferentiation in about a third of the patients, and 5 out of 14 in the BRAF wild type. Patients received 300 millicuries for the therapy. And if you take thyroglobulin as a marker for response, decline was seen in 4 out of 7. As I said, these are small numbers, but it tends to be an option. We don't know about an overall survival benefit. Of course, you need additional studies and more patients to really assess the advantage. And on the other side, since we only treat for a short period of time, most of the treatments are well tolerated by the patients. There was a real hype about redifferentiation. You all know that when the Alan Ho publication in New England Journal of Medicine came out, everybody was going crazy about redifferentiating patients. And they also did a very smart approach using iodine 1, 2, 4, PET-CT for dosimetry. And everybody was overwhelmed by the results. But in the end, this is 10 years, 12 years ago, and it doesn't seem to be the magic bullet. It's another option. We have several options now. As I told you, we have registered drugs. We have even the watch and wait strategy in many patients when they're not so aggressive. So it's one of the tools in our hands. Finally, I already mentioned prostate-specific membrane antigen, of course, primarily used in prostate cancer. Some institutions will also go for somatostatin analogs and FAPI is experimental. So we also were interested by using PSMA in other malignancies, especially thyroid cancer, because it's a marker of angiogenesis, and of course the PSMA expression may promote vascularization. So you could image PSMA, or you could use PSMA for thyroid cancer imaging. I'm going to show you a few examples here. On the lower line, you can see the FDG, and this would be PSMA here. And you can see in this neck lesion, it would be positive on the FDG only, but it can also be positive on the FDG and even very high, and very easy to differentiate uptake on the PSMA here. And another example here, you can see this bony lesion in the spine, which will only be positive on the PSMA. So I don't know, it may be a future tool, and there are some publications out there. And of course, we were motivated to also try and link PSMA to lutetium for the treatment, like we do in prostate cancer. And we like investigated a small series of patients after all kinds of prior treatments, so sort of last line treatment. And there was uptake there, and we could achieve like a stabilization of the disease. But of course, this is not finally convincing data. This is just explorative data and probably first in man use. So we will see where this takes us to, and if we have another treatment option there. The same for lutetium DOTA. Some groups tried to use lutetium DOTA, and there was 2 out of 5, but the studies are not consistent in a way. FAPI, also big hype in Germany. We use it for imaging, and it seems to be very promising in several entities, especially for monitoring of metastasis. But if it could be used for treatment, I'm a little skeptic due to binding phenomena and some other logistic problems. Few words coming to the end about anaplastic thyroid cancer. You know that we have a neoadjuvant treatment now consisting of lenvatinib and the pembrolizumab. We also use this, and also used FDG for staging. I'm going to show you one more patient. Is a male patient suffering from an aggressive tumor T4 with pulmonary metastasis, and he was treated with lenvatinib in combination with the checkpoint inhibitor. And this is the corresponding image, and you can see that after treatment, all the lesions are really shrinking, and they're going down. Even in the lungs, they almost disappeared after the combination treatment. So very promising in this aggressive tumor. And after another 17 days, the patient became operable, and even in the neck lesion, there was no evidence of vital tumor cells. It was pure necrosis. So very convincing. Is this a game changer? I don't think so. Again, it's just a case, and you shouldn't base all your conclusions on just case reporting. So finally, risk stratification. I hope I convinced you that this is eminent for treatment planning. We need uniform classification systems. Functional imaging is becoming bigger and bigger, and molecular markers are even more important. We need large prospective studies. Probably this is something that could be done in India. And there are new modalities on the market which should be tested in larger patients. So I'm not so sure if less is really more. Although I have stolen this from Julian Sosa, chairing the ATA task group, looking forward to these guidelines. Less is more only when more is too much. This is what Frank Lloyd Wright said. And that's, with this, I'd like to finish, and thank you for your attention. Thank you very much.
Thank you, Dr. Marcus Lester. That was an awesome presentation, and it was an eye-opener to all of us where we normally believed differentiated thyroid cancer and spectrum of thyroid cancer can be just treated with surgery and radioiodine. We understood many new aspects of the management of thyroid cancer, the dynamic risk stratification relevance, and also the newer drugs, especially the TKIs and also the experimental radionuclide therapy. So we are happy to inform you and to say that more than 150 people have attended this program, and I have more than 20 questions from the chat box and also to my WhatsApp and also from YouTube. So I will just try to put some of these questions together, and we will take 15-20 minutes if it is okay from your side.
Certainly, my
Dr.
pleasure.
Lester, some of the initial questions, because you told minimum number of lymph nodes that are to be examined by the pathologist depending on the T1 to T3 stage. One of our colleagues have asked, what is the minimum number of lymph nodes that are to be resected during a surgery? That is one question. And I also add one more question from one of my surgical oncologists. Is there a real role for sentinel lymph node biopsy in differentiated thyroid cancer? If not, at least will it be helpful for the pathologist to concentrate more? These are the questions, initial questions on the surgical aspects.
Oh, thank you very much. Very interesting questions. So I think I tried to show that the number of resected lymph nodes should also be linked to the tumor stage. So if you have an aggressive tumor, even more lymph nodes should be resected, which is most of the times the case in our hands, or our surgeons do that. If you have a very low risk tumor, my best guess, my best answer would be that the minimum number should be 5, but we also get referrals from other hospitals where you have 0 affected out of 1. So that probably doesn't make too much sense to have just 1 lymph nodes. I think the minimum number should be 5, but I think your surgical colleagues know better. But I just wanted to draw your attention that lymph nodes play an important role in the assessment. And if you don't have a sufficient number of lymph nodes, you shouldn't call a patient N0, because this will probably not impact on the survival too much, but it will certainly impact on the progression-free survival. So the patient needs to be operated again. Sentinel lymph node, there have been various approaches to establish the concept of sentinel lymph nodes, also in thyroid cancer, which is always very elegant and charming, but I don't know any prospective data showing a superiority. So we don't do that on a regular basis. If you end up having 5 or 10 in the low-risk patients, you don't need probably a sentinel. You just go there, take them out. That's as not being a surgeon, that's my best
Second question, Dr. Lester, is on you told about over and under treatment with radioiodine. So many comments have been there. So I will just try to put it together. One comment was, what do you mean by over treatment? Does it mean treating the low risk patients with radioiodine? Do you feel that is over treatment, or when we try to get rid of the residual thyroid tissue so that the follow-up becomes easier with serum thyroglobulin, is it over treatment? That is one question. And the second question is, when you have persistent pulmonary deposits, especially in children, how frequently we should treat? And every time, is there any so-called highest dose? You cannot go beyond that. And how frequently we can treat? That is the second question. Third is, what is the relevance of lobar ablation? do we have anything called lobar ablation, and what is your comment? There are many questions, but I will first put up these three questions. One is, what do you mean by over treatment? Second is, what is the how to approach persistent pulmonary deposits in children? How frequently we can treat? How many times we can treat? And how much should be the highest dose? And the third one is the relevance of lobar ablation.
Okay, thank you again. I like the questions very much. First, I think it's an open question. There is no definitive answer. I just wanted to have this eye open that we have been too aggressive, probably in the past, in low risk thyroid cancer. This doesn't mean that we have to skip this procedure in every single case, but in the absence of data, one may question himself if we really need aggressive treatment for a tumor that was completely resected. So over treatment probably also means that not in every single case we should be aiming at an undetectable thyroglobulin. This is probably not the final treatment goal, which takes me to the second question. Especially in kids, we have to balance our approach. If you are too aggressive, especially in metastasized patients, you may cause more harm than benefit to a patient. In our series here in Germany with 500 patients, we had just one young patient dying from thyroid cancer, and he was not dying from the disease itself. He died from pulmonary fibrosis. So they treated over and over again, 5, 6, 7 courses of radii. So I wouldn't do that. There's a very nice publication from Dr. Biko, the Chernobyl series, where we stopped treating patients after 5 radii treatments, and still the TG would continue to go down. So my argument would be, especially in young patients with a very long prospective survival, one should not be too aggressive. And my goal would not be to aim at a TG of 0, even if they're lung lesions. Just check and try to do as little as possible. Do a CT scan once in a while, see if there's real progression, and then react. Just to have standard approaches every 6 months or something does not help in young patients. In elderly with a shorter life expectancy, you can be more aggressive, but these young patients will probably live another 80 years. So you really have to balance with the side effects. And what was the third one? Sorry.
The third one is, what is the relevance of lobar ablation?
Yeah, lobar ablation, of course. I mean, our colleagues from surgery tend to be less aggressive these days. So if there is a huge remnant left, and there is no signs and symptoms of tumor left behind, I will probably just follow the patient and not ask for a completion procedure, not even ask for radiation. If there was a vocal cord palsy, damage to the recurrent nerve, then of course, and the patient is high in the high aggressive spectrum, then you can do a lobar ablation. But in low risk patients, I would just probably watch and wait.
Two more questions on the treatment aspect with radioiodine. First one is, do you routinely do or do you believe the relevance of pre-therapy dosimetry, whole body iodine scintigraphy? If yes, what is the dose of radioiodine you give? Do you believe in the concept of stunning? And which is the best radio tracer? Is it iodine 123, 131, or if available, 124?
Yeah, let me start with the last one. Of course, INA 124 is an excellent tool because of the half-life. You can examine the patient over a week or so, which is always nice for a medical physicist to have a lot of time points to really assess the doses to the organs at risk and to the tumor itself. But this is not a realistic scenario. I don't know what the situation in India would be. We had several experiences, but it's very costly. It can be shipped, but it's costly. So we don't do that on a regular basis. We tend to do iodine 131. We use 10 megabits if we have a high risk patient, and if probably there are certain circumstances like iodine overload with contrast media and the high-risk patient, or if there is already lung disease that may restrict our treatment, then we tend to do dosimetry. We don't do it again on a regular basis, but only in selected patients using iodine 131 and doing regular scans over, let's say, 96 hours. This is actually what we also recommend in our respective study now. Iodine 123 is possible, but you can only do few images over limited time, of course. And then my physicists always tell me we need the late time points to really make an assessment of the half-life and the residence time in a given organ. So iodine 123 is better for imaging, probably not the perfect radionuclide for dosimetry.
Is there a role for external radiotherapy in day-to-day practice with advanced differentiated thyroid cancer, especially in brain lesion? Do you believe treating these patients with radioiodine? Before that, do you need to use external radiotherapy?
Yeah, extremely rare, of course. Brain lesions are linked to poor prognosis, as we all know. We use external beam for distant metastasis. We use it for brain lesions. We also use it for bone lesions, of course, especially if they cause pain. We would usually go for a round of radioiodine first, see how the patient reacts, and all this has to be covered by steroids, of course, if they have a potential swelling in limited spaces like the brain. But I can't remember, although limited experience, to have great success using radioiodine in brain lesions. So if we have brain lesions, we would call neurosurgery if it's resectable. And if it's not resectable, I think this is an excellent place for external beam. The same, as I said, holds true for bony lesions.
Coming specifically to radio-resistant differentiated thyroid cancer, one of the definitions of radio-resistant thyroid differentiated cancer is use of radioiodine more than 600 millicurie. Still lesions persist. Do you really believe that? And is there going to be any change in this concept?
I think this is a concept. This is based on weak evidence, and talking to the authors, actually they were misinterpreted. It doesn't mean that you can't continue treating patients with radioactive iodine. All that has been shown is that you won't cure a patient. Once you reach this level, there is no chance of cure. But if there is still response, looking at, let's say, RECIST or PERSIST, and looking at the TG, of course, you could continue using radioactive iodine. So there is no absolute number. I think this was also part of the last question. I would keep on treating patients as long as I can see response to the treatment. And response also means stabilization if you had progression before.
Established patient of radio-resistant DTC, is there a specific time when to start TKIs? That is one. And sometimes will you go back to radioiodine therapy when patient is already on TKI?
First, I think we have to make sure that the patient is really progressing, because some of the patients will have widespread disease, but you can't really tell if it has been there for quite some time. So I always like to find out about the dynamics of the disease. So if there's real progression, especially causing symptoms, but then sometimes it's too late. So if there's real progression, and we as nuclear medicine people, we rely on FDG imaging and also have like the general performance status of the patient, then I think it's good to introduce TKIs, but we have to be aware we won't cure the patient and it's causing side effects. So the optimal timing should take into account several aspects, including quality of life, and you have to instruct a patient that we're getting there, and looking at the TG and looking at the FDG on a regular basis, let's say every 3 months or so, we have an aggressive course of the disease. This is what we rely on. And coming back to radioactive iodine, occasionally, yes, but usually since we tend to start later with TKIs, this is a rare thing happening.
As a continuation of one of our previous questions on management of intracranial metastasis with radioiodine, one of our colleagues is asking, is there a size criteria where you have to decide you can use radioiodine for this much size, or you should definitely go for a metastatectomy by surgery? Is there any size criteria?
That again, evidence is sparse, and I think there is no strict size criterion. It's more linked to if it's symptomatic or not. If it's 2 millimeters and it's causing symptoms, then of course you probably use the expertise of a neurosurgeon. If it's 1 centimeter, it doesn't make any problems. You can sit on it, wait and control, and probably go for external beam first. But frankly speaking, I rarely came across patients that will have a good prognosis suffering from brain metastasis. So usually it's quite aggressive, and this is not the only place of metastasis. So we need a concept as a team, including neurosurgery, radiation oncology, nuclear medicine, all kinds of, probably even ablation for some. I showed you the example with the liver metastasis. Of course, it was responding to radioiodine, but it was like 10 centimeters and was really causing pain. So we tried to go for a surgery. And sometimes you need a real individual approach.
There are still lots of questions, but I will just put some important questions. In one of the cases you showed mixed FDG positive and iodine avid disease, would you still continue radioiodine? Will TG follow up or this TG response will be a disease indicator?
Yes, usually if it's at least not completely undifferentiated tumor, we will follow TG. If it's anaplastic, of course, TG doesn't help. And if it's a very aggressive undifferentiated tumors, TG sometimes doesn't help. But we use it even as a criterion for a response to lenvatinib. So, of course, you can monitor a patient using the TG, and we will base our approach, be it increase of the dose, even pausation, even drug holidays, to the TG. I think it's an excellent tool, and in combination with functional imaging, that's the best you can get these days.
The next question is, what is your opinion and experience on redifferentiation therapy with TKIs, present TKIs, and will you like to specifically point out some of their specific side effects?
Usually redifferentiation doesn't last that long, so the spectrum of side effects is lower as compared to a long-standing treatment. So at least in our opinion, the patients won't suffer that much from redifferentiation. I'm always questioning patient selection. So if you have a very aggressive patient, I would rather go for established treatment using multikinase inhibitors and do mutation and fusion testing first to select the right treatment. Redifferentiation does work. There are papers from Sophie Le Bouleux and from others. But in our hands, it's not our first choice in many patients. And you use the short 2-3 weeks pre-treatment period. You need a nice assessment of the uptake. You need a quantification of the uptake, but overall outcome is still debatable.
One of the specific questions on poorly differentiated thyroid cancers. What is the role of I-131 in poorly differentiated tumors?
That's an easy one. I think there is no role for iodine-123. No iodine testing in poorly differentiated. We usually give it a try. If let's say if the pathology report is not crystal clear, undifferentiated thyroid cancer, we just offer the option to the patient to have one course. Usually with not too much hope. Sometimes you're surprised, as I showed you, and one patient is FDG positive, and the same lesion is also IDA 131 positive. But you need a response assessment. You really need to show that the patient will benefit from the treatment, and most of the patient will benefit from the treatment.
We are really overshooting our time, but I will just complete this discussion, excellent discussion with you with a very relevant practical question that has been put as the one of the last questions. Role of radiotherapy in post-operative setting in a patient with spinal metastasis causing cord compression and the timing of radioiodine therapy.
If there's cord compression, that's an emergency. I would always go for other modalities first, because radioiodine takes a long time, weeks, months even, to show some response. So spinal cord compression is, as I said, an emergency. Talk to your neurosurgeons or talk to your radiation oncologist. This always come first, and then it can be followed by radioactive iodine. The lesion or the patient should be covered by steroids to make sure once the lesion is swelling, using one or the other modality, you won't cause paralysis. But spine metastases are, again, quite dangerous. They're treatable, but you need a multimodality concept.
Thank you, Dr. Luster. It was a great interaction for all of us with you. And not only your talk, the discussion that followed was really practically highly relevant, and we really learned a lot. And I'm happy to say that the discussion we had is of one of the highest qualities, and this is going to be available as a YouTube recording. I'm sure many more of our nuclear colleagues will be benefited with these discussions, and it is really fulfilling for us to note this Amrita International online lecture series always is highly relevant with clinical questions, and this discussion we had was very great. Thank you very much once again on behalf of our institute, and also on behalf of all the delegates who participated in this discussion. Thank you.
Let me thank you as well. Sorry to interrupt, but it's a great pleasure to be here. Thank you for the invitation. Thank you for the audience. I really enjoyed all these questions, a very high level discussion, and you really took me to the test, but I'm happy to be here. Happy I was here. Thank
you, Dr. Luster, once more, and I thank all the delegates who have taken their time off on a Saturday evening to participate in this program. Thank you very much once again, and we will be closing this live discussion. Thank you very much.
Thank you. Pleasure being here.
Thank you.
Thank you. Bye-bye.